Good morning. I am going to briefly talk about menstrual cycle, contraception, and infertility. During our lecture times, we don't have a huge amount of time to cover all of these topics. So I just want to highlight a couple components to this, highlight some things kind of like need to know information for your course material. When it comes to our recorded lectures, please feel free to jot down some notes and questions, and you can always bring those to class and we can follow up on your questions at that time. Or feel free to email Lindsay or I with your questions as well, and we'll be able to help you get those answered as well. Okay, so let's dive in straight away. I want to begin by talking about the menstrual cycle. So here we're looking at an average cycle that occurs over 28 days. It's broken down into the ovarian cycle and the uterine cycle. The stages of the uterine cycle are influenced by the levels of sex hormones released from the ovaries. So on day 0, the anterior pituitary gland is releasing hormones FSH and LH. Follicle stimulating hormone and luteinizing hormone. These hormones affect the development of follicles in the ovarian cycle. So this is the start of the follicular phase of the ovarian cycle. And you can kind of see here the different kind of phases and some information that is going to tie with what I'm sharing. So this information will help you make better sense of what's happening in this image here on your slide. So again, as I was saying, this is the start of that follicular phase of that ovarian cycle. It's really easy to remember, you guys, because FSH is that follicle stimulating hormone. So it's stimulating the follicles in hopes to create a dominant follicle to create an oocyte. As the follicles try to compete to become that dominant follicle, the number of granulosa cells that create those follicles are increasing, and those cells secrete estrogen. So the days that these follicles are kind of growing and competing and becoming larger, there's an increase in those estrogen levels. While all this is occurring with the follicles, let's talk about what's happening in that uterine cycle as well. So those increases in those follicles, therefore the number of granulosa cells, is going to cause that increase in estrogen like we had talked about. We have our endometrium lining going through what's called the proliferative phase during this time. I remember this by knowing that the lining is proliferating or growing because of that estrogen. It's creating a new layer to that endometrium because the old one had shut off in the previous menstrual cycle. Now, when the hypothalamus and anterior pituitary gland in the brain start to sense the levels of estrogen getting super high like this, they begin to reduce that production of FSH and LH. They dip prior to ovulation, which makes sense, right? The point of these hormones was to cause development of those follicles. And then when those follicles make all of that estrogen, it's going to signal that pituitary that the FSH and LH have done their job. Now, those granulosa cells, which make up those follicles, again, as they become bigger, they are secreting that estrogen, but they're also creating 2 other hormones in larger amounts. That's your hormones of progesterone and inhibin. Inhibin helps trigger the pituitary to stop releasing FSH in addition to the high estrogen levels. So as you see, inhibin rises, it causes that dropping of the FSH. Interestingly enough, though, as estrogen reaches these like super high levels, it kind of turns back and it says, wait, I actually want FSH and LH. So then the estrogen gets so high that it all of a sudden spikes an abrupt increase in FSH and LH. But on the picture, you can see that LH only gets spiked, not the FSH. So why is that? Well, I told you earlier that those granulosa cells, the ones that make up those follicles, were also releasing inhibin. Remember, inhibin is preventing that release of FSH. So this is keeping that FSH from spiking as high as that luteinizing hormone. This stage is called the luteal surge. So this happens roughly 1 to 1.5 days prior to ovulation. Women that are using those ovulation kits, this is like checking to see if that hormone is being detected. So those ovulation kits are looking for that LH to tell the women that, hey, it's time to engage in intercourse because ovulation is going to be occurring. So that high amount of LH and somewhat high amount of FSH basically pushes that egg out of that dominating follicle and releases it during that ovulation process. Now, the ovarian cycle has now gone through the follicular phase and it's reached that ovulation phase. So let's talk about the next phase, that luteal phase now. Luteal phase is constant. It consists of 14 days. So why is it called luteal? Well, let's talk about it. So we have this egg that has been expelled from that dominant follicle. Well, you still have the remainder of that follicle that the egg was expelled from. We know that LH is really high, as we had talked. Well, that high amount of LH and somewhat higher level of that FSH is going to turn that old follicle, you guys, that old follicle structure into what we call a corpus luteum. Remember, the follicle, which was made up of those granulosis cells, is what created estrogen. Well, since it's not technically a follicle anymore, estrogen levels start to decline and it actually starts to mass produce progesterone instead. Ovulation, again, we know has occurred. An egg is released, and then there's that potential for that sperm to come and fertilize the egg. The egg is going to need a place to hang out and grow. It's going to have to implant into the lining of that uterus called the endometrium. What would be an ideal environment is a vascularized uterine lining that our egg could implant into to support gestation of our new embryo. The embryo at this stage is actually called a blastocyst. So you can think of progesterone as like a pro-gestation hormone. Progesterone mainly stimulates the uterine lining to prepare for implantation and gestation during a phase of the uterine cycle called the secretory phase. So progesterone does a few things in that secretory phase. It increases the blood flow to the endometrium by development of these special arteries called spiral arteries. These allow that embryo to have really good access to nutrients from the mother's bloodstream. Progesterone also causes uterine secretions from special glands in the endometrium, which are really important for the nourishment of that embryo. Progesterone also reduces the contractility of those uterine muscles, so the growing embryo doesn't get too disturbed. The corpus luteum's job is to produce lots of progesterone to help make these things happen. That corpus luteum will suppress the development of FSH and LH from that anterior pituitary, and this corpus luteum does produce inhibin as well, which spikes when that corpus luteum reaches its maximum size. Unfortunately, the corpus luteum needs FSH and LH to survive. And so it will start to atrophy and wither away and die off if pregnancy does not occur, which will then cause a drop in the estrogen and progesterone levels, which reaches the end of that luteal phase and will start the cycle all over again. That endometrium lining that you just spent time building up is now going to shut off if pregnancy does not occur. However, what will happen if pregnancy does occur? So we talk about how LH is needed for the corpus luteum to survive, right? Well, when that blastocyst implants into that endometrium and gets really cozy, you guys, the resulting embryo that develops from the blastocyst starts to produce a special hormone called the human chorionic gonadotropin hormone, or HCG, which is structurally very similar to LH. So this is what's going to keep that corpus luteum alive when pregnancy occurs. So with it remaining alive, it can continue to produce the estrogen and progesterone that's necessary to maintain that healthy vascular uterine lining supporting that pregnancy. When a woman takes a pregnancy test, that HCG hormone is what the test is trying to detect because it's a hormone that is special to pregnancy. The corpus luteum will produce that progesterone production for roughly the first 2 to 3 months. And then after that, the placenta will take over for the production of that progesterone. This is another visual aid to help you understand what's happening in the ovarian and the uterine cycle. So I really like this one because I feel like it does give you a better visual that's easier to understand. So, like we had talked about before at the beginning, those estrogen levels are really low. And so your follicle stimulating hormone is being triggered here. And remember, those follicles are trying to compete to become that dominant follicle. And those granulosa cells are playing their part. And with those granulosa cells, we're having this massive increase in the amount of estrogen, right? Well, while that follicle is becoming dominant and increasing that estrogen is going to play a role within our uterine cycle. Here we're having that proliferative phase of our uterine cycle, which is influenced by that estrogen, and it's causing that thickness of that endometrium. Okay, it's prepping that endometrium. So once that estrogen gets really high, it's going to trigger that luteinizing hormone. Okay, so you can see LH here kind of smacking out the egg out of the dominant follicle here. So this is where ovulation is taking place. Okay, so after we release that egg, then all of a sudden that shell is left. And we talked about how that can become that corpus luteum, and it's now going to secrete that progesterone. So if pregnancy doesn't happen, that's going to start to wither away, and all those hormone levels are going to drop. And then that is when you would have the start of your period. Within that uterine cycle, when that progesterone is starting to be secreted, remember that's going to help that endometrium become really vascular and edematous and kind of prep in case pregnancy happens. But again, if that pregnancy doesn't happen, all of a sudden those hormones are going to drop because of that corpus luteum kind of withering away. And then your body's going to say, oh, we no longer need that uterine lining that we just built up, or that endometrium lining that we just built up. So now we're going to shed that off. And then the cycle is going to start all over again. So hopefully that kind of helps you put those pieces together. This slide can also help break down the cycle in these different phases. So you can see the Menses phases, the follicular phase, the ovulation phase, and that luteal phase. So between these three slides, hopefully this will help you identify what's happening during those different times and understand that menstrual cycle a little bit better. Now I'd like to jump into contraception. When we talk about contraception, I want you to think about the things that play into pregnancy and the things that play their role in pregnancy, such as when we have that ovulation happen, right? When that egg is being released or that ovum, and how, during that ovulation time, how it can be fertilized. So, and then that is where we could have that sperm come into contact and have it implanted into that uterine lining. So the things that I want you to understand is that the egg can be fertilized for up to 24 hours. So that egg will survive for 24 hours after ovulation, okay? Sperm's ability to fertilize that ovum can last up to 48 to 72 hours. So it's important for us to educate women that are trying to conceive to try to engage in intercourse as soon as that ovulation kit is telling them, like, hey, in 1 to 1.5 days, you're going to be ovulating, because that sperm lasts 48 to 72 hours. So if they can engage prior to ovulation and after, their chances are pretty high. Now, if they're trying to avoid conceiving, these are things that we also want to keep in mind, okay? So when we talk about contraception, these are going to be strategies or devices used to actually reduce the risk of fertilization or implantation to prevent pregnancy. So let's dive into those a little bit. Now, when we are meeting with women and trying to get an idea of what their plan looks like, we need to know kind of their needs, their desires, and their preferences for contraception. So, have they used contraception in the contraceptive methods in the past? What worked for them? What didn't work for them? What are their desires and needs? So, are they looking to refrain from getting pregnant for the next 10 years, the next 5 years, the next year? What does that look like? Because that will also dictate what kind of measures we're going to use. Is there anything else that they're struggling with? What's their menstrual period like? Are they having heavy bleeding, heavy cramp, or lots of cramping? So those are things too that we're going to want to screen for, because we can look at options that can also help manage some of their symptoms, or we may want to avoid options that could increase some of those symptoms. Making sure that we do a thorough discussion of benefits and risks and alternatives with our patients. Keeping in mind that we're also going to want to instruct our postpartum patients on contraceptive methods and have an idea and talk with them about, like, hey, we need to talk to you about, some future contraceptive plans, so that way we can avoid you getting pregnant and let your body heal for a significant period of time before you try to conceive again. And there's going to be certain birth control methods that we're going to want to avoid immediately after delivery as well. Also, nurses should support patients in making the best decision based off of their needs and their desires, because everyone's going to be a little bit different, right? When we talk about contraception methods, there's a lot of different methods out there. There's natural family planning, barrier methods, hormonal methods, intrauterine methods, as well as surgical procedures. So I'm just going to briefly highlight some of these different types of contraception, and we'll talk a little bit more about these in detail coming up. Abstinence. Abstinence is essentially just people avoiding engaging in intercourse. So that is eliminating the possibility of sperm entering the vagina. So with this, you would just have to instruct the patient, well, you would be refraining from intercourse, but maybe you could partake in other sexual activities with partners to where that sperm might not be entering the vagina. Some advantages with this one is that it's the most effective contraception method, and you're eliminating all risks of those STIs as long as there's no genital contact. Some disadvantages is it requires a huge amount of self-control, and there's a high failure rate. So understanding that abstinence is not going to be effective for everyone. People are going to have sex. So it's something that we have to talk about and do what we can to help our patients avoid STIs and avoid pregnancy when they're not looking to get pregnant just quite yet. Some risk with abstinence too is, there are no risks. Sorry about that with abstinence. So that is also a big plus. There's also, you can see here listed on the slide, natural family planning. So this method is kind of understanding when your period occurs and understanding your fertile days and your unfertile days. And essentially, you are going to prevent pregnancy by avoiding the days that you are fertile. So you're going to avoid engaging in intercourse during the times that you are around that ovulation time. So some benefits to this one is it's free and it's easy to use. There's not a lot of there's no side effects associated with it. Doesn't really affect fertility. And some cons with this one is that, it's roughly only about 75% effective. It does take a lot of time and patience to work because we need to identify your cycle and see if your cycle is regular. If you have an irregular cycle, this method is not going to be very effective for you. And it can be affected by illnesses, and it doesn't protect against STDs either. So just some things to think about with that natural family planning method. The other one that I wanted to hit on briefly is withdrawal method. So this is where you're removing the penis from the vagina prior to that ejaculation. So letting patients know that this can be a method, but guess what? It's not very effective because there's that pre-ejaculatory fluid that can leak from the penis prior to ejaculation, and that contains sperm, which can fertilize the ovum. So making sure that patients are aware of that. Some advantages with this one is it can be a choice for monogamous couples if no other contraceptive method is available. But again, it does not have high success rates. Some disadvantages, remember, it doesn't protect against STIs, and it's one of the least effective methods out there. And there is that risk of possible pregnancy. The calendar rhythm method, this helps, it's kind of similar to the natural family planning by like helping you determine your fertile days by tracking your menstrual cycle and also estimating that time of ovulation. So to prevent pregnancy, again, the patient should abstain from sex during the fertile periods. So with the education that you would give for this one is you would want to make sure to record, kind of keep a diary and record your days of your menstrual cycle. So you would start from the first day of bleeding for 6 cycles. Then you would subtract 18 days from your shortest cycle, and that would be technically the start of your fertile period, and subtract 11 days from your longest cycle, and that would technically be the end of your fertile period. So again, some advantages. It can be very useful when it's combined with other methods, such as like basal body temperature or cervical mucus method, and it's inexpensive. Some disadvantages is, again, it's not the most reliable. It doesn't work the best for people that have those irregular cycles. It does not protect against STIs. It does require record keeping of your cycles and making sure that you're like being consistent with that. And it does also require adherence to abstain during those fertile periods. So again, some risks with this one would be those things that can impact and change the menstrual cycle, and possible pregnancy if you miscalculate and you engage in intercourse during your fertile window. This is another method called the standard days method. It's kind of cool because they have this visual aid here of this kind of like bracelet looking thing. So you can see here that you start the first day of the menstrual cycle, and then you use this like rubber ring to advance 1 bead per day. So that red bead is the first bead, which marks that first day of the menstrual cycle. The brown beads would then be your non-fertile days, and then your white beads would be your fertile days. So this is pretty cool for those that like a visual aid. There's also mobile apps that are available for this, and it can be pretty easy for patients to understand. However, this one is not great for people that have longer or shorter cycles. You can see in the slide there, greater than 32 or less than 26 days. And you can lose track of the days. So you do need to remember to continue to advance that rubber portion of your ring there. Some risks: not effective if cycles are short or long, possible pregnancy, and less effective with hormonal contraceptives, IUDs, and breastfeeding as well. Basal body temperature is another method. Honestly, I don't even bring this up as a method really to educate on, just because of the different things that really can cause a fluctuation in your temperature, but it is something that you can still incorporate in your teachings, and they could use it in addition to like other methods to be more accurate with their methods, or to have more reliable methods, I should say. But basal body temperature, this is where they're going to monitor their temperatures. because around prior to that ovulation time, that temperature drops slightly and then rises with ovulation. So you can see here some instructions that we would provide the patient about when we would want them to be taking their temperature, and then helping them understand those temperature changes that they would see to help them identify when their fertile days would be. So some advantages with this one is it's inexpensive, it can be convenient, it doesn't really have any adverse effects. But the disadvantages are, again, all those different things that could influence the temperature, like stress and fatigue and illness and alcohol and warmth of your sleeping environment. There's just a lot of things that can impact your temperature. And it does not protect against STIs either. Cervical mucus ovulation detection method. So as you can see here, we also know we call this the Billings method. This is where we have patients kind of assess or analyze their cervical mucus and the changes that they see, which can help them determine where they're at in their cycle. So after ovulation, the cervical mucus becomes really thin and flexible under the influence of estrogen and progesterone to allow for that sperm viability and motility. The ability of mucus to stretch between the fingers is greatest during ovulation. And then the fertile period begins when the cervical mucus is thin, slippery, and lasts until like 4 days after the last day of the cervical mucus having that appearance. So some education that we would want to do with this one is making sure that they're using the calendar method to really increase efficacy with this. Obviously, good hand hygiene since they're assessing their cervical mucus, making sure they clean those hands. And then the mucus is obtained from the vaginal introitus. It's not necessary for them to reach into the vagina all the way up into the cervix. So just letting them know those things. Again, advantages is it's cost effective, not a lot of adverse effects. So there are some benefits to this, but accuracy can be challenging. And also just that patient education and interpretation, like that patient interpretation, could lead to errors with this method too. Here is just some information about the 2-day method that you see here. Again, and this is just involving checking those vaginal secretions. You're not really analyzing it, you're just like assessing it. So education that you would give is just like if vaginal secretions were present 2 days in a row, then avoid unprotected intercourse to prevent pregnancy. So this is just, again, another method that they can use, but honestly, the reliability of this one's pretty low, so this isn't something that I normally advise. Barrier methods would be things like your condoms. So you can see here a vaginal or a female condom and a male condom. The more common ones that we run into are those male condoms. You can see on the slide here the different types of elements that these condoms are made out of. Some are like latex rubber, polyurethane, natural membranes. So these not only help avoid pregnancy, but it also helps prevent the transmission of STIs. However, we need to make sure that patients are putting them on properly and have proper removal, letting them know that you can use these in conjunction with spermicide. But they do want to make sure that they're checking their expiration dates of their condoms. Natural skin condoms, letting them know that those do not protect against STIs. And only water-soluble lubricants should be used with latex condoms. Advantages, they are very readily accessible. There's not a lot of adverse effects. And again, the prevention of the transmission of STIs is huge with the advantages of condoms. Disadvantages is it only works if it's used, right? Can reduce spontaneity of intercourse. So, you're in the heat of the moment. And unfortunately, this is something to where you have to kind of pause to make sure that you are using your protection to prevent that pregnancy. It can also decrease sensation. One-time usage, so you use it and you toss it. So then you need to think about the replacement costs of that too. It does not protect against STIs transmitted from lesions on the skin or mucous membranes. So just keep that in mind and make sure that patients are aware of that. And these can break and can leak. So there are some of the cons or disadvantages still with condoms. So again, making sure to thoroughly inspect the condoms prior to use is important. This is a slide on just female condoms, not as commonly used. I feel like they're just not as, accessible, and they're just a little bit more harder to use compared to male condoms. So you can see here what the female condom looks like, the education of how to insert it. We would want to provide to the education or provide that education to the patient, excuse me. Similar advantages with this one. One of the benefits to the female one is that it does offer a little bit more protection against those STIs transmitted by the skin-to-skin contact, just because of how this female condom is positioned and what is covered. Some disadvantages would just be, again, it's kind of complicated to use. It's very bulky. It's noisy during intercourse. It's more expensive than male condoms. Honestly, I don't really see these too commonly being used, and I don't have a lot of patients even ask about those. So not a common birth control method that we see too much anymore, but the male condoms are still very common, and we still want to encourage those regardless of whether patients are using birth control, contraception, or hormonal contraception pills or anything else to prevent STIs. So something to think about. Spermicides. This is a chemical barrier that also helps destroy sperm before they enter the cervix. It causes the vaginal flora to also become more acidic, and that's not favorable for sperm survival. So making sure we do provide education that spermicide should be administered 15 minutes prior to intercourse, and it's only effective for 1 hour after insertion, and it should not be removed until after 6 hours from when they engaged in intercourse. Some advantages: no prescriptions are needed. It does increase the effectiveness of other methods of contraception when they're used together. And there are various preparations available with this. The disadvantages are it's pretty messy. You do have to reapply after each act of intercourse, and it does not protect against STIs. Some other risks and contraindications is we don't want to use these or we want to educate that patients shouldn't be using these in patients that have cervical infections. And then spermicides have this chemical called N9, and this can cause lesions and increase the risk of HIV if it's used more than twice daily. So clients that do have a high risk for STI should not use any products that contain that N9. So just something to be aware of. And then we have your good old diaphragms. Again, not something that I literally sit and say, oh, let's talk about diaphragms. It's kind of gone out of practice, but still good to just know the education that we would give in relation to this. These are kind of like a dome-shaped cup with a flexible rim, and they're made of silicone, and they fit snugly over the cervix. So these do need to be fitted by a provider. You do need to replace them every 2 years, and there's a lot of different times that you would need to get refitted for it, such as weight fluctuations, after surgeries, and after pregnancies. It should be inserted into the vagina over the cervix with spermicidal jelly that is applied to kind of the cervical side of the dome as well as around the rim. It should be inserted up to 6 hours prior to intercourse, and it should stay in place for 6 hours after intercourse, but make sure to remove it before that 24-hour mark. Spermicide should be reapplied with every act of coitus, making sure to empty the bladder to decrease pressure on that urethra before that diaphragm is placed. And then it should be washed with mild soap and water after each use. You can see some of the advantages and disadvantages with this one. Also, be familiar with the risks and complications as well as contraindications for this one. You can see some things listed for toxic shock. So we don't want to use these in patients that have a history of toxic shock or like pelvic organ prolapse or frequent or recurrent UTIs. So keeping that in mind, as well as there is that risk of allergic reaction, and again, UTIs with the use of these diaphragms. Oral contraceptives, aka the pill. So you'll see OCs, which stands for oral contraceptives, COCs for combination oral contraceptives. These are composed of like differing amounts of natural estrogen and synthetic estrogen combined with a small amount of synthetic progesterone. Estrogen acts to suppress the follicle stimulating hormone, FSH, and luteinizing hormone to suppress ovulation. Progesterone acts to decrease the permeability of cervical mucus, limiting sperm mobility, and access to the ova. Progesterone also decreases the endometrial proliferation, and that thereby decreases the implantation of a fertilized egg as well. So types of COCs, there's monophasic, there's biphasic, there's triphasic, and tetraphasic. So when we talk about monophasic, keep in mind it's a fixed amount of estrogen and progestin throughout like a 21-day cycle. Biphasic is going to contain a constant amount of estrogen, but varying amounts of progestin. Triphasic and tetraphasic, that's going to vary in both the amount of estrogen and progestin throughout the cycle. A lot of times these pills are going to be supplied in like a 28-day pill dispenser. 21 of them are going to be active pills, and the 7 will be placebo pills that they'll take during that withdrawal period. When they're used correctly, you guys, they are 99.9% effective. And you can see some of the benefits here too from COCs. It can help with dysmenorrhea. It can help with iron deficiency anemia. It can do so many things, possibly even plays a part with reducing like osteoporosis, endometriosis, uterine fibroids, and rheumatoid arthritis, can lower LDL, but increase HDL cholesterol levels. So lots of benefits with taking those COCs that we have come across. How to start COCs. So you can see here on this slide, we have a couple different ways that we could look at starting a woman on combination oral contraceptives. There's the Sunday start, which is where they take the first pill on the first Sunday after the beginning of their menstrual flow. There's quick start. So this is where they literally just take the pills as soon as they're prescribed. The benefits to this is it does increase compliance and reduce unintended pregnancies when we do the quick start. First day start is just beginning the pills on the first day of menses. And then after childbirth, a patient should start the contraceptive on like a day or preferably like a Sunday closest to 2 weeks after birth or after like an elective termination of pregnancy. They could choose a day or that first Sunday after that procedure. Those COCs are not effective for the first days, so just reminding patients that they do need to use a backup method for those first 7 days. They need to be taking the pill every day to prevent pregnancy. So whatever they need to do to remind themselves to take their pill. Combined oral contraceptives, so the ones that have like the estrogen and progesterone based hormones in them, those are a little bit more forgiving if you miss it like by within, are able to take it the same day, but maybe you missed it by 10 hours, but you're still able to take it in that same day. A lot of the times you're safe with that, right? But with progesterone only ones or progestin only pills, those have to be taken literally same time, exact time every day. So you do have a little bit more leeway with the combined oral methods. This slide, you can see here, has a list of, okay, what of these different scenarios of if I missed one pill, what should I do? What if I missed two? So we just put this on here to help you better understand what patients should do in case a pill or two pills were missed and what we should tell them to do and if they need to use a backup method. So I'm not going to dive into this, but just please make sure that you're feeling comfortable with what you would tell a patient depending on what their situation is. Again, progestin-only pills, we also call these the mini pills. These only contain the progestin. These have to be taken, like I said, you guys, same exact time every single day. Without that estrogen content, ovulation can still occur, but because the progestin have not allowed that endometrium to develop fully or sperm to freely access the cervix, fertilization and implantation won't take place. So common side effects of hormonal contraceptives you can see here. So a lot of the times patients might experience some mood changes, nausea, possibly some headaches, some possible weight gain, vaginal dryness, skin problems, disruptions in their hormone levels. So letting women know some of those common side effects that are associated with those hormonal contraceptives is important when we're discussing contraception in clinic. Also letting them know of when to call the provider. And you can use this acronym of ACHES, okay? So if they're experiencing abdominal pain, chest pain, headaches, eye problems, and severe leg pain or swelling of legs and feet, we do want them to make sure to call the provider right away. Estrogen-based oral contraceptive use contraindications. So there are contraindications for the estrogen-based oral contraceptives. A lot of them are going to be more cardiovascular related, or if they have like a history of a blood clot, or if they are a smoker and over the age of 35, they have migraines with aura. These are things that increase their risks of clotting. So therefore, we would not want to prescribe them with oral contraceptives that have estrogen, because that estrogen component that makes them more susceptible for those things. So please be familiar with this slide and what we would want to be screening for and making sure that we're not seeing any of those contraindications if we are looking at a combined hormonal method for them. The transdermal patches, these are just like patches that you place on the skin, and they're going to slowly and continuously release a combination of estrogen and progesterone. The patches are going to be applied each week. So maybe it's like every Sunday, you're going to change out that patch. Okay. You're going to apply it for a full week and then change it out that every Sunday. You're going to do that for 3 weeks. The 4th week, no patch is applied. Okay. That is for your withdrawal bleed. After the patch-free week, a new cycle of 3 weeks on, 1 week off will begin again. Again, efficacy is going to be very similar to COCs as long as they are abiding by the rules and using them properly. But these can be less effective in patients that are obese. Again, they do contain estrogen, so same risks for those thromboembolic symptoms that we see with COCs as well. Contraceptive patches, you can see here the different areas or sites that you can place the patch. We do encourage patients to rotate the site just because it avoids skin irritation. We want to make sure they're putting the patches in areas where there's like no makeup, no lotions or creams being applied, and where, we don't want them to obviously place it on the waist where they're bending, and then that can cause that patch to become more loose. Again, if they do have skin irritation, making sure that they don't place the patch on top of those irritated areas. If a patch does become loose, the patient should remove it and immediately replace it with a new patch. No additional contraception is needed for the patient if they are sure that that patch has not been loose for, 20, like for less than 24 hours. However, if they're like unsure and they don't know, then what we would have them do is just remove it, apply a new patch, and just kind of like start that new 4-week cycle over with a new day 1 and a new week to change that patch. So in that case, just to be safe, we would have them use a backup method for the first 7 days. The NuvaRing and Anovera. So these are the different vaginal rings that you could see. These are inserted vaginally and left in place for 3 weeks, at least the NuvaRing, I should say, the NuvaRing is. And then we'll remove the NuvaRing for 1 week for that withdrawal bleed. And that would be your ring-free week. The NuvaRing is discarded after that 4th week and replaced with a new one. So every month you should be placing a new NuvaRing. However, the Anovera can be reused for a whole year. So it does not need to be replaced every month. Same kind of process where you will keep it in for the 3 weeks and then you will do the ring-free week and then reinsert it after that ring-free week. Rings do not need to be removed for intercourse. Again, effectiveness, as long as they're used correctly, is similar to COCs. If patients do take out the ring for more than 4 hours for any purpose, they need to replace it with a new ring, like the NuvaRing, and also use a form of barrier protection for the next 7 days. The things with the vaginal rings is it can increase vaginal discomfort as well as non-infectious vaginal discharge. And so those are things that we're going to want to educate the patient on. Nexplanon. So this is a subdermal hormone implant. This will be embedded in the arm. It's a minor surgical procedure that they would come into the office for. This will slowly release progestin over like a period of 3 years. So again, very small, minor procedure. And this can be a great method for women that don't feel like they can remember to take a pill or replace a patch on like a daily or weekly basis. If the patient is switching from one reliable method of contraception to the implant, it can actually be placed at any time. If they are inserting the Nexplanon and they have not been on birth control, we do want to make sure that they are either on their menses or no later than day 7 of the menstrual cycle to make sure that the patient is just not pregnant at the time that we insert it. It can be placed immediately also after an elective termination of pregnancy or 6 weeks postpartum. Again, the implant is effective with a failure rate of less than 1%, so pretty good outcomes with that. Some side effects could be irregular menses. So some women might have heavy bleeding, some might have spotting, some might have breakthrough bleeding, others might have amenorrhea. So it does vary person to person. We have seen some increase in depression symptoms. You can have some minor scarring at the insertion site. And depending on like side effects that you're experiencing, there could be that possible need for removal. Some contraindications would just be pregnancy, or obviously if there's undiagnosed uterine bleeding, we're going to want to identify what's causing that bleeding prior to us inserting like this birth control option. Depo-Provera. This is an IM injection of depomedroxyprogesterone acetate. This is given every 12 weeks. So this one, the effectiveness rate is almost 100% as long as they come in and they're getting their injections at the time that we are, at the time that they're needed. It can be a very or I should say it is a popular contraceptive method. Basically, the IM is going to go into one of the major muscles, either the buttocks, deltoid, thigh, before the 5th day after the beginning of those menses. We do want to make sure that they don't massage that injection site after administration because we want that drug to absorb slowly from the muscle. They can use this during breastfeeding, but we ideally don't want to initiate this until 6 weeks postpartum. You can see some side effects associated with this one include like headaches. I do feel like we see more weight gain with the Depo-Provera compared to other birth control methods. Also, a higher incidence of depression compared to other methods. Irregular heavy menstrual cycles for the first year is often reported, and then a lot of people experience amenorrhea after that. We do also see an increased risk for diabetes and osteoporosis. So we do want to make sure that we're instructing our patients to increase their calcium intake and also make sure that they're doing weight-bearing exercises to avoid those things. Because Depo-Provera actually has a black box warning for patients not to use this method longer than 2 years, just due to protect them against that bone loss. Again, remember this one, they are required to get that injection every 12 years for it to be effective. Intrauterine devices. So these are kind of like these small plastic devices that will be inserted into the uterus through the vagina. IUDs can be hormonal and non-hormonal, and they are nearly 100% effective as well. Again, really great choice for people that are wanting to avoid pregnancy for years, and they are terrible about remembering to take something either on a weekly basis or daily basis. Really great method for those individuals. Usually an IUD will be placed before a patient has had intercourse after a menstrual flow, just to make sure that the patient's not pregnant at the time that we insert it. However, if the patient is switching again from a reliable method to this method, then we can replace or place that IUD at any time. The copper IUD can actually be placed within 5 days of unprotected intercourse as a form of emergency contraception. So that is something that we could consider with the copper. Speaking of copper, there are 4 different types of IUDs. So there's the Paragard, which is the copper one, and that's approved for 10 years, but is likely effective for 12. There's the Mirena and Liletta. With these ones, progesterone diffuses into the uterus, preventing both endometrial proliferation and thickened cervical mucus. It's effective for 5 years. The Liletta has been FDA approved for 7 years. There's the Skyla. It has a lower dose of progesterone than the Mirena, and that one's effective for 3 years. And then there's the Kylena that has the lower dose than the Mirena and is effective for 5 years. All of these IUDs have a failure rate as low as 0.1%. IUDs are really appropriate for patients, again, like I had said before, that just aren't really great at remembering to take something on a regular basis and that are refraining from, wanting to start a family for quite a few years. These ones can also be appropriate for patients at risk for estrogen-based side effects. The copper IUD, though, just keep in mind, can cause menstrual flow to be heavier and can cause more cramping. So if that's something that a patient's already experiencing, we're probably going to want to steer away from the copper IUD. Other hormonal IUDs could cause decreased menstrual flow or even amenorrhea. So just providing that education to those patients that they could see some changes in that menstrual flow or even not have a menstrual flow after this is placed. Vasectomy, this is a type of procedure that can be done on the male. You can see just kind of the image here, and this slide gives you a little bit of information about how this is done. So this procedure is about 99.5% effective. And just keep in mind, too, that it's important to let the patient know that if there was sperm in the vas deferens at the time of surgery, like that can remain viable for as long as 6 months. So the patient can resume intercourse within 1 week, but they should be using other birth control methods until the patient has had 2 negative sperm reports at that 6 and 10 week status, and making sure that those have been obtained to truly avoid pregnancy. Usually that requires about 10 to 20 ejaculations. And then also letting them know that this doesn't necessarily interfere with the production of sperm. The testes continue to produce sperm. It's just that the sperm doesn't get past the plugged vas deferens or the vas deferens and are absorbed at that point. So the patient will still have like full erection capacity and continue to produce testosterone as well. They will also continue to make seminal fluid. It's just that the ejaculate seminal fluid, they will ejaculate seminal fluid. It just will not contain sperm. Complications occur infrequently, but they could include things like a hematoma at the surgical site, pain, and/or kidney stones. Letting patients know that this is technically a permanent contraception. So reversals are complicated, expensive, and have low success rates. So patients that are looking for vasectomies or tubal ligations, it's really important to have that conversation of like, you need to be 100% sure that you're not wanting any future pregnancies or wanting to have more children. Speaking of tubal ligations, this slide is covering just that, as well as the self-injectomies. So these are different procedures that could be done too. As you can see, there's a 99.5% efficacy rate. It's laparoscopic, same day. Patients might have, 1 to 2 days of just kind of some abdominal discomfort. Some possible complications could include like bowel perforation, hemorrhage, risks associated with just like general anesthesia if it was used. They can return to intercourse as soon as 2 to 3 days after the procedure. Patients will still have a monthly menstrual flow after tubal ligation, so just letting them know that. And again, this is considered like a permanent contraception. So just going over that information is really important for patients as well. Now, there's also emergency contraception. So we talked about how the copper IUD could be used. And then there are the morning after pills, which can prevent fertilization by inhibiting ovulation and the transport of sperm. So making sure that we do provide education on these. It should be taken within 72 hours of unprotected sex. Oftentimes, or it can cause like nausea, so they should try to take an over-the-counter antiemetic an hour prior to taking the dose of this medication, just to prevent that nausea that can occur because of those high doses of that estrogen and progesterone in these. Make sure that we explain to them that they should be evaluated for pregnancy if menstruation doesn't begin within 21 days after taking their emergency contraception pills. And then provide counseling about contraception and modification of high-risk sexual behaviors. So some risks, obviously this method is going to be contraindicated if a client is pregnant, or again, if there's undiagnosed abnormal vaginal bleeding, because we could also be worried about an ectopic pregnancy. The last thing I want to touch on is infertility with this content. Infertility can affect up to 10% of women in the United States aged between 15 to 44. And when we talk about infertility, it's women that either have difficulty getting pregnant or staying pregnant. Infertility is used to describe the inability to either conceive a child or, again, sustain a pregnancy to birth. A couple is infertile if they have not conceived after at least 1 year of unprotected sex. If the woman is aged, she's above the age of 35 then we could also go off of the time frame of 6 months, just because we know that she has a shorter window. Subfertility is another term that you might hear. This is a term that, like, most couples have potential to conceive, but they're just less able to without some help or assistance. So that's where this term subfertility came from. Subfertility can affect as many as like 14% of couples. So just so you understand the different terminology that might be associated with cases of infertility and those preconception counseling visits. This slide just has some signs and symptoms of male infertility and common causes of infertility for females. As you can see here, there's not too much for symptoms in association with male infertility. Men just might notice maybe some erectile or ejaculation issues. Rarely is there like even testicular pain. Some signs could just be like an abnormal semen analysis, maybe some hormonal imbalances or blockage in reproductive tracts. For females, some causes of infertility might just be like the woman's age, a tubal disease, or problems with her fallopian tubes. She could have some ovulation disorders. Maybe she has like polycystic ovarian syndrome or endometriosis. Fibroids could play into this. Pelvic inflammatory disease caused by sexually transmitted diseases. So that's where it's really important to continue to provide that education to women when they're engaging in sex, especially like sex education at an early age, the importance of condoms and protecting yourself against sexually transmitted diseases, because it can cause things like infertility in the future. When it comes to assessment and treatment, the nurse's role is just to provide education on kind of the overview of infertility evaluation, things like basal body temperature monitoring, some counseling, and assessing their understanding of fertile times. Some treatments might include some medications, surgical options, therapeutic insemination, also known as intrauterine insemination. And then keep in mind the different assisted reproductive technologies. I'm not going to go over these in detail, but you can see all the different ones that are listed out on your slide. The one that you might be familiar with is in vitro fertilization, where that sperm and egg are combined in a lab. And then the 3 to 5 day old fertilized egg is transferred into the uterus. So you can see the different ones where the sperm and egg are combined in a lab tube. But for this one, the 2 day old fertilized egg is put into the fallopian tube. So fallopian tube here, uterus here. With this one, they're combined in a lab. And then the 1 day old fertilized egg is placed into the fallopian tube. So different names depending on where it's going and when it's placed. And then there's also embryo cryopreservation. There's micro manipulation, pre-implantation, genetic diagnoses as well. So lots of different things that we can come across with infertility treatments and assessments. The last thing that I wanted to mention with this module is just understanding all the emotional aspects that come with infertility and how that can impact a patient as well. So making sure that we are addressing those factors and getting them the help that they need and helping them identify some healthy coping mechanisms and maybe even referral to a mental health professional if this is something that has been causing a lot of stress between them and their relationship. So just another thing to think about when we're taking care of patients, especially in the infertility world. That is all I have. So again, if any of you have questions, please feel free to reach out to Lindsay or myself, or you could bring your questions to class and we would be happy to go over those. Thanks, everyone.